My current role from the ACPS is as the Chair of the Education Board, which is the overseeing board to the education arm of the college. The Education Board is made up of members from quite a diverse background of academics, community representation and podiatric surgeons with appropriate background and experience in governance and or education. I'm also chair of the training committee, which is a subcommittee of the Education Board, and have a direct involvement in curriculum development. That largely because of my own background in surgical education and history of education within the university sector over a long period of time. Prior to that role, I was a previous president of the college and held various council roles before becoming president of the college over around about a 20-year period. So I have had a long association with governance in the college, both from a policy perspective, from an advocacy perspective, but more recently primarily focusing on education. Determination. Pursuit of excellence. In the first instance, we're very cognitive of the need to ensure that applicants to the college understand what it means to be a podiatric surgeon as distinct from a podiatrist or even as distinct from a surgeon from any other discipline. The role is quite diverse, it's quite challenging, and it's one that we would like to think people understand well before they come into the profession. So we have quite a rigorous admission protocol which involves pre-vocational training, it involves interviews, it involves experiential learning, all designed to satisfy that goal of ensuring that the best people come into the training program. Now there's a multiple purpose to that. The program is arduous. It takes several years of dedication. It's difficult to balance career development with family, with finances, with the stresses and anxieties of higher learning in an adult learning environment, whilst developing professionalism and a capacity to continue to collaborate with other healthcare practitioners and patients. It's quite a difficult job. Our focus is getting to the point where the college training program is able to justifiably graduate individuals who have enough background to be able to independently function as a foot and ankle surgeon in this country. So that whole process is structured to facilitate that. For decades, the college training program has been based upon the curriculum design of similar educative programs in surgical specialties. Initially modelled upon US residency programs, we've also relied upon input from other colleges, such as our colleagues in the UK, and we've also borrowed from and built upon the excellence that we've seen in other training programs, such as those offered by the Royal Australasian College of Surgeons, the Anaesthetists College, the midwives, so that we have commonality and with all of these types of specialty programs. We're in that fortunate position where we have the flexibility to be able to look for the best and implement the best to the best of our ability. The college training program is constantly evolving, and this based upon the evolving healthcare system in the country, responding to the needs and educational development within the Australian healthcare context, also responding to feedback from external accreditation authorities and as per the Australian Healthcare Regulation and Accreditation Scheme. So we're not fixed, we're not rigid, we're constantly shifting the soil. Now that will present itself in many different dimensions. So for instance, one of the dimensions that we've recently introduced is a compulsory component of the curriculum around cultural awareness and sensitivity, which is in direct response to the initiatives that are being promoted as appropriate, and I agree, entirely appropriate, by organisations such as AHPRA. So we're on the front foot, we have the capacity to introduce these types of programs quite quickly. And that's just one example of many. We have innovative programs around international rotation so that our registrars are exposed to different health systems, they're understanding different funding systems in different countries, and they're getting exposed to different ways of practicing around the world. So there are several programs that we develop and utilise, but constantly looking for ways to improve our program. The Australian public is our focus. Delivering appropriate, best care for what are generally chronic conditions of the foot and ankle. We're out there to try and improve mobility. That's more difficult than it sounds. The foot and the ankle is very, very complex. And the evidence for intervention across not just surgical, but even non-surgical care can be quite sparse in many areas. And this is common to all areas of, not all, but this is common to many areas in medicine and surgery. So our goal is to be always offering an evidence-based approach to improving mobility through surgical care where necessary. But more importantly, we are educated in non-surgical care for foot and ankle pathology. This is our grounding, this is our base. All of our practitioners, all of our registrars, all of the college members have an extensive experience in these areas. So a lot of our focus is on finding ways to avoid surgical intervention or find alternatives to surgical intervention where appropriate. Surgery is not the go-to option. Surgery is just one option in a continuum of care. And for foot and ankle, that's what we can deliver the Australian public. A continuum of care which is specialist, truly specialist, that crosses right around through non-surgical options, including things like counselling and ergonomic shifts, all the way through to surgical care where necessary, collaborating with different healthcare practitioners all the way through. That's what we offer the public, that's what we've been doing for decades. And we were the first group to really be looking at that type of innovation. Within 5 to 10 years, I believe that podiatric surgery will be normalised within the Australian healthcare system. That's important. At the moment, podiatric surgery is still treated by some on the margins. We have difficulty in terms of equity of healthcare funding. We have difficulty in equity of access. We have difficulty in access, sometimes in delivering collaborative care. These things need to change. They are slowly and incrementally changing. I would firmly believe that within 5 to 10 years, proper integration and normalisation of what we do so that we can be an unencumbered member of the healthcare team in this country, just as our colleagues are in the US and the UK, and to a large degree, I believe, in Canada as examples. Australia has to wake up and has to catch up.